Good afternoon, everyone. First, I thank the organizers for this opportunity. Today, I'll be discussing three abstracts. The first one is the second interim analysis of the Keynote 355, pembrolizumab plus chemotherapy in advanced triple-negative breast cancer. It was published in NEJM, July 2022. So, cytotoxic chemotherapy was the standard of care in management of metastatic TNBC, but it is often associated with suboptimal tumor response and short overall survival. Earlier studies have demonstrated that pembrolizumab monotherapy has shown durable response in patients with metastatic triple-negative breast cancer, especially in patients with higher PD-L1 expression. For the first interim analysis of Keynote 355, pembro plus chemotherapy resulted in significantly longer PFS than placebo plus chemotherapy in patients with PD-L1 CPS score of 10 or more. Coming to the study design, it is a phase 3 randomized controlled trial where previously untreated metastatic triple-negative breast cancer were randomized into two arms in a 2:1 fashion to pembrolizumab plus chemotherapy versus placebo plus chemo. The chemotherapy regimens included were nab-paclitaxel, paclitaxel, or gemcitabine plus carboplatin, and treatment were continued till the disease progression or cessation of the study therapy. The primary endpoints were two, overall survival and progression-free survival in patients with both PD-L1 positive tumors and in the intention to treat population. The secondary endpoints include overall response rate, duration of response, safety, and quality of life. The stratification factors include the chemotherapy regimen received in the study and the PD-L1 expression, and also the prior treatment received in the adjuvant or the neoadjuvant setting. Coming to the results, among the 847 patients, 566 were assigned to the chemoimmunotherapy arm versus 281 to the placebo arm, placebo plus chemo arm. The median time since randomization was 44.1 months. Baseline characteristics were well balanced between the two groups. Regarding the tumor response, the confirmed overall response rate was statistically significant in the CPS 10 subgroup. It was 52.7% versus 40.8%. About the overall survival rate was statistically significant in patients in the subgroup of patients with CPS score of 10. And the median overall survival was 23 months in the chemoimmunotherapy arm versus 16.1 months in the chemo plus placebo arm, with a hazard ratio of 0.73 and a statistically significant p-value. The treatment effect of pembrolizumab on overall survival increased with higher PD-L1 expression, but similar treatment effects were observed among patients with CPS score of 10 or more or CPS score of 20 or more. About the adverse events, more than 98% of patients had at any grade of adverse event, both in the chemo arm, chemo plus immunotherapy arm, and most common side effects were cytopenias and alopecia. Immune-related adverse events were reported in 26.5% of patients on chemoimmunotherapy, and hypothyroidism and hyperthyroidism were the most common adverse events. So this conclusion was among patients with advanced triple-negative breast cancer whose tumors express PD-L1, with a CPS of 10 or more, the addition of pembro to chemotherapy resulted in significantly longer overall survival than chemotherapy alone. So CPS score of 10 or more is an appropriate criteria to define the population of whom to be expected to derive from chemoimmunotherapy, and the response increases with increasing PD-L1 expression, unlike in neoadjuvant therapy where the response is irrespective of the PD-L1 expression. The safety profile of pembrolizumab in combination with chemotherapy remained consistent with that in the previous analysis and without any new safety signals. The take-home message, chemoimmunotherapy with pembrolizumab is a current first-line management in patients with metastatic triple-negative breast cancer with a PD-L1 CPS score of 10 or more, and the regimen is associated with a statistically significant OS than chemotherapy. Adverse events were low-grade and manageable with dose interruptions and supportive care. The second abstract is a health-related quality of life analysis of this Keynote 355, which was published in this ESMO Cancer Congress. And patient-reported outcomes were assessed based on the quality of life questionnaire, and it was assessed during the trial and at various pre-specified time points. The primary analysis was done at week 15, And pre-specified primary endpoint was mean score change from baseline to week 15. So in all the quality of life questionnaires, there was a decline the quality of life with treatment, but all were comparable among the two groups. This is the QLQ-C30 questionnaire and the functional and symptom scales of the QLQ-C30. We can see that there is not much difference among the chemo group and chemoimmunotherapy group. The visual analog scale also the same. So to conclude, the addition of pembrolizumab to chemotherapy did not result in substantial deterioration in the health-related quality of life. The final abstract is article published in JCO Oncological Practice in November 2022. It's an oncologic perspective on individualizing dose selection for patients with metastatic breast cancer. We know delay in cancer progression, symptom relief, and prolonged survival were the goals in treatment in metastatic cancer. Appropriate dose selection is critical for balancing patient safety and treatment efficacy, but it often associated with toxicities, and dose interruptions or modifications are very common. And this is considered as a byproduct of the drug development paradigms, where this maximum tolerated dose is often identified by the early trials and which later recommended by the phase 2 trials. So this is a study. This is basically a survey among medical oncologists, treating breast and GI malignancies, and about the dose selection beliefs and practices when treating patients with metastatic breast cancer. Medical oncologists who are members of the ASCO were participated in this trial, and it was done through confidential electronic surveys via email. A multidisciplinary task force developed a novel questionnaire which is based on the current practices and experiences, factors considering selecting starting dose, beliefs about starting dose, all these things. So 3,099 oncologists were approached, and among this 367 were participated. The median age was 47 and more than 50 were males. More than 90% had experience in leading clinical trials. The general experience with dose reduction, more than half of the respondents reported using dose reduction at initiation for patients with metastatic cancer sometimes or usually to limit toxicity. And oncologists of age 40 to 49 years had the higher response rate of the DRI. And oncologists who reported DRI, most of them suggested that they inform patients regarding this dose reduction. Among the factors influencing the decision-making for dose reduction, this include patient's medical condition, potential side effects, evidence from previous studies or guidelines, or the oncologist's prior experience with the drug. And about the beliefs about starting dose, more than 70% believed that the initial dose should be based on the patient preference for balancing efficacy and the risk of side effects. About 40% oncologists they prefer to start at the lower dose of drug and then to consider increasing the dose if it is well tolerated. And more than 70% oncologists, they believe that they should start with the recommended dose of the drug and then lower the dose in future in case of potential side effects. And regarding the dose reduction by specific agents, among the metastatic breast cancer, capecitabine was the most commonly dose reduced at treatment initiation. And for GI malignancies, regorafenib was the most commonly dose-reduced agent. So, this survey highlights the need of dose optimization strategies. And in the era of this less toxic immunotherapy and targeted therapies, the role of this MTD on selecting the dose is to be revised. The strength of this study is the largest study to date emerging the issue of dose selection, and the results contribute to evolving discussion about the dose optimization. The limitation, as you can see, only 300 among the 3,000 were responded, so the low response rate, which is there is a potential for selection bias. So survey among breast and GI oncologists, so it cannot be generalized to oncologists from other specialty. And most respondents were part of the clinical trials, and their approach for dose optimization may differ from oncologists who are not involved in clinical practice. And to conclude, DRI is common in patients with metastatic breast cancer and GI malignancies, both in US and internationally. but the frequency of dose reduction in specific drugs is highly variable. Most oncologists believe that the starting dose of a drug in patients with metastatic disease should be based on patient preference for balancing efficacy and toxicity, and this suggests a need for dose optimization in both drug development and clinical practice. Thank you.